It's like opening new doors in retinoblastoma. When I was listening to the previous talks, and this is exactly how I was feeling, how to get out of it. I was stuck because I'm a hardcore clinician and I can't do or think of basic research, but I can definitely uh, tell you what is my wish list, and maybe you can work on it. So a few years ago, retinoblastoma had a very poor prognosis. 60 to 70% of children ended with enucleation, and life salvage was 2% in 1900s. Now we have totally reversed it to more than 98%. So there has been a dramatic turnaround. But can we do something about this 2% is the question. And also, can we improve eye salvage, which is currently hovering around 70 to 80%? Can we make it 90% plus? For that, we have to work a lot in terms of imaging, classification, customized focal therapy, newer forms of chemotherapy, and maybe multimodal treatment. In imaging, we have REDCam, which is a fundus imaging under general anesthesia, wide field fundus imaging. We have FFA that can be done with REDCam. We have OCT, which can be done under general anesthesia, which helps in screening, diagnosis, and monitoring response. The newer use of OCT is to classify vitreous seeds into epiretinal, subretinal, and various other forms of intraocular seeds, which has helped us design treatment for them. So imaging wish list would be something which is inexpensive, portable, which has a higher resolution, can be used in smaller pupil, and multimodal imaging, which can be networked. So if that can be worked out, then that would personalize imaging in retinoblastoma and also care of these children. In classification, we had staging and grouping. We have the international staging. We have international grouping, which prognosticates life and eye salvage respectively. What is new in classification of retinoblastoma is the AJCC 8. For the first time ever in all forms of cancer, H has been introduced. Otherwise, it was TNM. Now it is TNM H. H for heritability, where genetics has been brought into prognosis. So this is a very big change, I feel, and that has to be further optimized in terms of personalized prognostic factors. Genetic and molecular information can be used specifically for multi-drug resistant and metastatic potential of a kid. So that will help us prognosticate. In focal therapy, of course, the goals of management of retinoblastoma are always salvage of life, salvage of the organ, and salvage of function. In small tumors, focal therapy is the key, and our aim is vision salvage. We began with laser photocoagulation, which was done around a tumor, thus resulting in a large scar, vascular occlusion of the sort, visual field defect, internal limiting membrane rupture resulting in vitreous seeds, and it also reduces chemotherapy uptake. So it's no longer used, and we have shifted over to thermotherapy, which is a gentle form of inducing tumor cell apoptosis. It is done right on top of the tumor, and it classically prevents blockage of the blood vessels, and the scar is never larger than the tumor itself. It can be done in parafoveal posterior polar tumors as well. A higher magnification picture showing that blood vessels remain nice and patent. A newer form of TTT is chromophore enhanced or ICG enhanced TTT, which can be used over non-pigmented scars. For example, this was a recurrence over a non-pigmented scar treated with ICG enhanced TTT. So we should probably look at more such options of chromophore enhanced TTT and also image guided focal therapy with temperature sensitive colorimetric endpoint, because the assumption in when we do TTT is that we are increasing the intratumoral temperature to about 45 to 60 degrees centigrade, which induces tumor cell apoptosis. But we really can't know how much is the tumor temperature increase, because we depend on a clinical endpoint. But if we were to have image guided or thermal sensitive endpoints, which could be or may not be colorimetric, then we can further optimize TTT to keep it sub-photocoagulative. Sub-photocoagulative TTT is very important to do, otherwise it will cause all the complications that we encountered with laser photocoagulation. Further, there is scope for optimized PDT and chemophore enhanced thermotherapy with minimal collateral damage. There are already works that are going on in this direction. Multifunctional nanoparticles have been used with focused ultrasound and immunosynergistic therapy for retinoblastoma and also for melanoma. This is already in the experimental stage. In chemotherapy, there was a paradigm change in the management of retinoblastoma. It reduces the size of the tumor, and tumor always regresses towards its source of blood supply. For example, here the supratemporal arcade is the source of blood supply. Tumor has regressed towards it, thus freeing the macula and fovea very early in the course of treatment, thus optimizing vision. Shrinks the tumor, it resolves exudative retinal detachment, and thus enhances the scope of vision. Intravenous chemotherapy was the standard of care until 2000, but the prognosis with intravenous chemotherapy for higher grades of retinoblastoma was suboptimal. Then we brought in intra-arterial chemotherapy, which is super selective ophthalmic artery delivery of chemotherapy using a 400 micron catheter. That has changed the prognosis of retinoblastoma. But what is the scope for newer forms of chemotherapy? There are several ways of delivering chemotherapy. Intra-arterial chemotherapy, we use standard three drugs, topotecan, melphalan, and carboplatin, with dramatic results, as you see here, pre and post. Large tumors regress to very nice scars. But the issue with intra-arterial chemotherapy is that it is very expensive. Technologically, we are not challenged at all. We have very high rate of cannulation, but the cost seems to be the only barrier. It makes a huge difference in the eye salvage of group D and D retinoblastoma. So possibly we have to make the treatment less expensive in terms of cost of treatment for intraarterial chemotherapy. And for further accuracy, we can probably look at robotic cannulation, which is already a reality in other subspecialties. So in ophthalmology, this is not coming yet, but there is some scope for a rapid cannulation of ophthalmic artery. Otherwise, interventional radiologists take a while to cannulate or get into the ophthalmic artery. Sometimes they're not successful, but this way of doing it may be more helpful. For intraocular seeds, there is a new classification. We used to call them all vitreous seeds earlier. Now we have further categorized them as classic vitreous, prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal, and even intracameral, we have depository and infiltrative seeds. For all these, we use intraocular chemotherapy. Now, intraocular chemotherapy is initially was in the form of melphalan. You can see very nice effects of melphalan. These 3 or 5 vitreous seeds are completely gone. But what we started to realize was that with melphalan, there is retinal pigment epithelial atrophy and also the higher incidence of cataract, uveitis. It also needed multiple injections, weekly injections, and retinal toxicity. So we have further customize this by moving over to intravitreal topotecan, which is a gentler form of intravitreal injection, which is given 3 weekly. So it is spaced out injection, not needing weekly general anesthesia. Works beautifully well. You can see focal vitreous seeds gone. You can see diffuse vitreous seeds completely calcified with intravitreal topotecan. And we have been using it for even for refractory seeds. We use combination of topotecan and melphalan. So what is currently new about intraocular chemotherapy is that it's being used for anterior chamber seeds. Intracameral topotecan is used for anterior chamber seeds. As you see here, anterior chamber seeds gone with intracameral topotecan. 5 microgram is the dose that is used. And also further extended uses for subretinal seeds, which were earlier lasered. Now with just intravitreal injection, these subretinal seeds go away. So possibly there is a scope for using intravitreal chemotherapy for smaller tumors, if not for larger tumors. This is one, again, a bunch of subretinal seeds gone without laser with intravitreal chemotherapy alone. So we think that RBCs have been conquered, but there is further scope for customization by using epibulbar drug delivery systems, drug depots, which is called chemoplaque, which Dr. Galley has already put into trial, intraocular target therapy, and gene therapy. This is the trial that is registered on topical topotecan episcleral plaque, which is called chemoplaque, and there is scope for further improvisation of this technique. Following enucleation, we still had about 20 to 30% mortality. Then we came to identify histopathological high risk factors that govern this mortality. So all patients with histopathological risk factors currently receive adjuvant therapy, and it definitely helps because it reduces the chance of mortality from 24% to less than 4%. That makes a survival benefit of 20%, which is very good. It was evaluated in a multicentric study and that was accepted. So enucleation is not the end, but there is scope still for risk stratified adjuvant therapy. All children need not get chemotherapy because we realize that only a quarter of them who have clinical risk factors, histopathological risk factors, develop metastasis. So 75% of children are receiving adjuvant therapy, whereas they don't need it. So there is a scope for identification of risk and making it really crystal clear as to which category of children would actually need it and would benefit from it. Regarding genetics, I think it's very well worked out genetics of retinoblastoma. There is nothing much to talk about except the fact that liquid biopsy is coming in a big way. Use of aqueous as a surrogate measure for analysis is supposed to be more effective than using blood. This is a study by one of the groups from California. And there is also possibility of using non-invasive pre-implantation genetic testing assisted reproductive technology. That means that you select out a particular embryo which does not have the mutation and then implant pre-implantation screening that will help eradicate retinoblastoma in families altogether. About uh, parental screening for children with retinoblastoma using apps. There is a scope for AI-based analysis of fundus reflex as a predictor, thus ruling out false negatives. So there has been a lot of work on life salvage, eye salvage, and vision salvage in retinoblastoma, which has taken us to about 98% life salvage and about 60 to 70%, maybe 80% eye salvage. So with all these personalized medicine, we have a scope for further improvement. There's definitely scope for optimization of care and prognosis. So possibly this is the way to go. Thank you so much.